We'll talk about surgery, and surgery is the main stem of treatment of melanoma in the past. Dr. Snow, an English surgeon, at the autopsy saw melanoma, such devastating tumor. And those days were late, so he devised a method of not only excising the melanoma with a big 5-centimeter margin, but also with the removal of the in-transit pathway. And we have come a long way since then. With that, you see that melanoma incidence is going up, and you see this slide again, about 70,000 new cases a year that we're dealing with. But 8,000 probably would die, and this death rate probably will be lowered with the treatments that you have heard just now. Here is what Dr. Kashani has shown you very eloquently about the characteristics of melanoma. And hopefully every one of you, when you see a lesion either in your body or in your friend or in your spouse, will quickly refer the patient to a melanoma center. The principles of biopsy is important because most of the time it is seen by a primary doctor or a dermatologist. And these are some of the details involved. But this is the important picture that Dr. Miner sets the tone, the microenvironment of the tumor. You can see the tumor, a lot of geographical areas surrounding that tumor. The very fact that this tumor now can grow into the vertical growth and down to the subcutaneous tissue is the evidence of the fact that it has now escaped the immune response. And through cancer evolution, which is based on the principle of Darwinism, is now beginning to launch its journey. And here's the cartoon. Just take a minute and look at these cells begin to migrate. And they actually happen real life like that. You can see the cell going through the lymphatic channel. The video is not playing as well. Let me see if I can. Okay. Maybe the juice is not enough. But here, the principle is here. It goes into the lungs and into the sentinel lymph node. Now, this is a very important picture because Dr. Morton, one of the leading surgical oncologists, just really within the last 20, 30 years, dominated the field and just passed on in 2014. He himself is a victim of melanoma, early stage melanoma, once recurrence, resected, and then he developed Hodgkin's disease. After 2 courses of chemotherapy, he responded, but because he's an MD, distinguished surgical oncologist, Santa Monica, the medical oncologist said, we got to give you more. So he got 3 more doses and wiped out his heart. He died of heart failure. The last hours when Mark Ferris told me that he was very happy that his MSLT1 paper was finally published. In fact, that included Dr. Kashani as a co-author, and he passed away. But the key thing that I want to show you is that he basically thought about sentinel lymph node. And here is the key, is that one spot will go to one lymph node rather than go to the whole basin. This spot here will go to maybe this lymph node. That's the key. And so with that, we have devised techniques, a blue lymph node, a neoprobe approach to find sentinel lymph node. And you can see why, because you can see that traditionally we will take such a big block. Now we just take this tissue out, and 80% of them would not have to go additional surgery. And that's a lot of block of tissue to result in large lymphedema, which even if you survive the patient, and I hope that Laka will talk a little bit about that, lymphedema is a big problem. He and I both see the patients, and this is a silent complaint of the patients when patients survive. I'm going to go this quickly. These are the sites that we do this routinely. We have now done between the combination patient referral at UCSF, and now when Dr. Kashani and I moved over here six years ago, we have done over 3,000 patients. So when a patient asks me, Dr. Leong, have you done anything? I say, I have done about 3,000. They just say, Dr. Leong, book me up for surgery. This is another site where the toe is a problem, very intriguing, acrolentigenous or whatever. All this, Dr. Kashani talked to you a little bit about the biology of it, so I'm not going to go over that. This is another site, head and neck. We have done a lot of research. So now Dr. Morton brought us to this era of micrometastasis. You can see one single cell right there. You saw the video, which was not played very well, but you have the sense of it, that lonely cell going through that journey and landed in this micro environment of the lymph node. And now this is the host reaction environment again. And we're launching several researchers, some of them with Stanford collaboration, using super resolution microscopy to actually see the interaction between this cell and this lymphocyte in a 1,000 times scale magnification, where the light energy cannot even distinguish, which can only distinguish at 400 times at the level of the microscopy. But we're going to talk about that. That's Darwin right there, evolution, because this lymph node this cell can be killed. This is totally subclinical. But when it goes to this big, it means that this clone now being selected as the fittest clone and it's going to survive. And we still don't know why. And we should be beginning to know that because all the molecular mechanisms, all the molecular information is pouring in. Dr. Kim talked about Avatar program. Dr. Kashani is really concentrating on that. Next generation sequencing, all that is going to bring us to this point why this cell grow from here to here. So the next one is that Dr. Morton's important study that sentinel lymph node positive patients do much worse than the negative group. And we have published that as well in collaboration with that data. You can see that. In addition, Dr. Boehner, at that time, a pathologist at UCSF, further delineated that the micrometastasis, in addition to the high-risk features of melanoma, gave rise to different survival curves. Now you can see not only on the molecular level, the heterogeneity of melanoma, but also on a histological level, on a clinical level. I'll show you some data as well, such as sites of the melanoma, types of melanoma have different prognostic implications. And all that is locked in within the molecular message of each melanoma, and so-called, therefore, personalized medicine by Dr. Kim. So here is the comparison of 3 groups of patients in our very large database. And Dr. Kashani, I want to thank you for your effort to support this database. And because of that, this is very basic clinical patient database where we collect one by one over, say, 1,000, 2,000. Now we can put them into statistical analysis. Not the molecular approach, but this is the observational level upon which molecular studies can be generated, new hypotheses can be generated so that trials can be conducted. That's the key. And this database is the key. So what we have found is that the head and neck melanoma does worse than the trunk and extremities. And we'll talk a little bit about that. Also, in doing the identification lymph node, we do preoperative lymphoscintigraphy. Some of you may have already had this procedure. And we found that different sites of the body, different patients have different kinds of lymphatic channels, either in terms of numbers and in terms of their geographical connections. We find that more channels involved, the patient do worse. And that makes sense because you've got more freeways now for the melanoma cells to travel. So here you can see different channels in the database. And here, if you have a trunk melanoma, they can even go into a sentinel lymph node within a breast. It's called intramammary sentinel lymph node. This was a case when a medical student was involved, and she was at UCSF then, was very intrigued by that. So I asked her. In the meantime, she became a resident, and finally we collected almost over 1,000 cases and found that 5% of the time in the trunk will go into the breast. And sometimes, therefore, when you have breast recurrence, it could be actually a lymph node recurrence. Here is the plan that, therefore, we have developed over this large experience of database. You have a melanoma initially, we took it out, we do sentinel lymph node negative, we do not do anymore, we observe the patient, we follow them. But if it's positive, we proceed with the lymph node dissection. Still, we're doing that. Perhaps in the future we can replace it if we can define certain subgroups that we don't have to do lymph node dissection. For example, in breast cancer, most of the time, in T1, T2 lesions, completion lymph node dissection is not being done now. This is a Lymphoseq, a new molecule that we finished phase 2, phase 3 studies, supported by NVIDIA. It's a molecule that will, as you can see, go into the cell and bind with the dendritic cells of the lymph node environment. And supposedly, by mechanistic assumption, that this molecule, once bound, will not come out of the cell. So we propose two hypotheses based on the data of the study, is that we know that there are multiple lymph nodes. Could it be that this melanoma goes to this lymph node, and then this is called the gateway, and then go upstream to 2 additional echelon lymph nodes? If that's the case, you don't need to remove these 2. The more you remove, yes, the more surgeries involved and more lymphedema. So without this molecule, we cannot really tell, because the next situation would be like this. And based on the preoperative lymphoscintigraphy, we cannot define these 2 mechanisms. But assuming the molecular mechanism of Tumandicet is correct, then this may be the mechanism if we see more than 1 sentinel lymph node. And we do see more than 1 sentinel lymph node. Here you can see this melanoma going through this channel, going through here, going through here. We can go to the East Bay, through Golden Gate, or through Bay Bridge. And in fact, at night, because of the last time they were reconstructing the bridges, people have learned that they can actually go back to the East Bay by Golden Gate. So every afternoon right now, Golden Gate is flooded. The traffic is so heavy. So I usually go home at 7:30, no problem. Here is where we dissect them ex vivo. You can see these intricate channels. There's about 100 microns. Barely you can see with the eye. But 100 micron just fits the melanoma to go through. The melanoma cells is about 40 to 60. So one of my theories about in transit is that we might have some fat melanoma cells, about 100 micron, barely coming through the channel, and they get stuck there. And they stay there for 2 years and they grow out. And this is very typical, is when those cells are caught in there and grow into the fat in transit. Very typical characteristic of melanoma pattern of metastasis, and I'll show you one slide later. But this is a nice shot of the connection between this lymph node and this lymph node, and you can see that even within the lymph node, there's a different distribution of radioactivity, meaning that there is a heterogeneous selection of taking the cells in at the time when the cells go into the lymph node. Here we can see most of them at this peak, the lymph nodes about 2 to 3. Some patients may have more, but very rare. And you can see it's very important to see that more lymph nodes are important for the diagnosis. Dr. Balkan, a UCSF surgical resident, rotated here at CPMC, did the study and found out that greater than one sentinel lymph node is significantly associated with tumor micrometastasis with a significant p-value. Very important finding. We're just about to send this to Annals of Surgery for this publication. Here is the new Sentinella. We just finished about 97 patients, and Will Lucker is working very hard to help me with the study. Painstakingly, 1, 2, 3, 4. By now, when I told the patient, you're going to be 95, 96, Dr. Leong, please sign me on. But the first 10, we're struggling, right? Well, you mean you only have done 10? The first one is a major struggle. So this is a Sentinella we have here. And we can, after the sentinels are removed, it's almost like a dark cave when you need neopro. And I can find most of the people sitting here, but somebody at the corner, I miss it. And this machine comes in, turn on the light, and I see the guy or the woman at that corner. Now I go back and take it out. So based on the previous slide, I show you that we found that more than one sentinel lymph node removed is very important. And this means that you should take out all the necessary lymph nodes. Again, it fits the mechanism that you may have multiple lymphatic channels. You look at this room, you got multiple doors that you can get in and out. Okay, here's what we did here. And we actually picked up some lymph nodes that will be retained and missed. Important finding. This is the 36-patient interval report. Now we have 97. 3 more to go to finish the study. Here's another paper that Miranda did for us, lower extremity melanoma. The problem is that you have lower extremity melanoma, and then the lymphoscintigraphy shows the inguinal identification lymph nodes, and also deep in the pelvis. So in this study, we actually went into the pelvis and took out the lymph node painstakingly, adding 2 hours in surgery. We were wondering, and oftentimes, I bothered Dr. Kashani at the end of the day, said, Mo, I think it's just too much to do that. So finally, we analyzed this data. And what she has found basically is that anything, the inguinal lymph nodes, that's the superficial ones, are negative. The pelvic lymph nodes are always negative. But when the superficial inguinal lymph nodes are positive, then occasionally the pelvic lymph nodes are positive. Well, I was sitting in the back of a conference, and that's why the conference like that is very important. You get new knowledge, new thinking. Somebody was talking about laparoscopic removal of lymph nodes in the pelvis. And I said, wow, maybe we can do that without doing open. Open is very tough surgery. So we developed the system. Here you can see distinctly this patient with a foot melanoma, draining the lymphatic channel into a large inguinal. This is the inguinal ligament that divides you from the lower part of the femoral triangle to the deep pelvis. This is the bladder here. Now we identify pelvis. We decided at this point not to do them, but to wait until the histology comes back. Negative, no pelvic surgery, follow. But positive, we go in. Well, we go in a different way, not open. Open is tough surgery. We use robotic. Here is robot docking to the patient, 3 different ports. And here's my surgical colleague, Dr. Heiler, past the chief of surgery at CPMC. And here's me. I think it looks okay here. but sterilized it here. So this is the box where he operated from here, far from here. This was developed during the Iraq War because they wanted to do surgery from Virginia to Iraq, but they were not successful. But this is the byproduct of robots. So what happened is that we'll go in and dissect them without tools, without hands, with the computer remote control. And this is all dissected very clean, even cleaner than growth surgery. Here's all the lymph node lined up. And this is the data we have: 8 patients with positive femoral sentinel lymph nodes, 1 with positive pelvic lymph nodes. Now we have a 12.5% positivity. And all these patients, 7 patients, did not have to go through the deep pelvic surgery. Here's in-transit metastatic melanoma I just talked about. And here's Dr. Kremens, my mentor back in Tulane, way back. He developed this perfusion in 1957. And I have his picture in my office. He developed this Dr. Kremens in action in New Orleans, Tulane University. And that time, in 1958, was the power center of melanoma. New Orleans, Louisiana. Kremens, everybody goes Kremens in the South. Okay, here's Dr. Thompson's approach. Well, Dr. Kremens, you're in the conference, I was there. You're a little too rough and tough. We will do infusion therapy. That's what they do at MD Anderson. And Thompson published and found out that pretty much the same result. And in fact, at MD Anderson, they use infusion rather than this perfusion. But now with all the revolutions in the treatment of melanoma, we're using this less and less, much less, which is good. Here is Dr. Kim's talk about BRAF, and he prepared me so well. And we have a patient, Dr. Miner, Dr. Kim's patient with extensive melanoma, stage 3, right there. Dr. Kashani and I look at him and just say, couldn't do it. So at that time, the BRAF was around. He was BRAF positive. We started BRAF. And then, look at that, shrunk all the way. We went back. Only 1 lymph node out of 53 lymph nodes show a microscopic tiny focus of melanoma. And this was published as a case report. Okay, this is my second last slide. And that's why I'm so glad that I'm in between the last one talk, because I am just sandwiched by Dr. Kashani, who was working very hard in this area, and Dr. Kim and Dr. Miner is working very hard. I work very hard here, try not to let this graduate from stage 3 to 4, Dr. Kim and Dr. Miner. But don't worry, when I get to 4, I will refer them to you. And this is the key, because we can study a lot in the sentinel lymph node, not just the techniques now. And for that reason, we are going to have an international symposium in April. I would like to invite you all to come. If you're interested, let me know. I have special registration rates for all the people who attended this meeting. It's downtown Holiday Inn on Van Ness. Dr. Kashani, Dr. Kim will be very much involved. And then the next one is the Lymphedema Clinic Summit on Saturday. There will be a workshop. It will be run by Saskia Thydens, one of the prominent therapists in the city, and several other invited guests. Thank you very much.